Welcome to Grand Rounds. Sarah Mike is going to talk today for the students. The responsibility of all graduating residents is to put together a Grand Rounds topic, and Sarah has picked Propofol and the PICU standard flow, so this shall be an interesting presentation. So, Sarah.
Can you guys hear me okay?
Yeah.
Me in the back? Okay. So, I chose this topic after I was in the PICU, and we had a kid that we had sedated with Propofol who developed some of the symptoms of Propofol infusion syndrome. And I know that we use Propofol a lot. We use it for sedation in the ER, we use it for sedation in our sedation unit for procedures, and occasionally we use it in the PICU. And I think for most residents, we're taught, and it's true, that it's a good drug, has a good side effect profile usually, has a good therapeutic use, but sometimes we don't think about what are the really bad adverse effects of the drugs we use. And I think it's important for all of us to be aware of it, to know what to look for, and to be aware of Propofol infusion syndrome in case you run into a patient who is sedated with it and they start to develop weird symptoms that you don't know what they're coming from, so that you know this could be part of a known syndrome that's associated with the use of Propofol. Hopefully you guys can stay awake. I won't sedate you like with Propofol, but if it gets boring, we're going to talk about some biochemistry, we're going to talk about some pharmacokinetics, and so I won't go into great detail, but we're going to harken back to med school and talk a little bit about stuff we probably haven't thought about in a while. So I don't have any disclosures, I don't have any conflicts of interest. I'm going to be talking about off-label use of Propofol, but not, for or against use. And so, this out of the way. We're going to talk about a little bit about biochemistry, about what the clinical usage patterns are, about Propofol infusion syndrome, what that is, how we define it, and then whether or not we can use the data that's out there to come up with a protocol for using Propofol in the ICU. Breaks this from bothering me. Okay. So in the 70s, we were looking for a new anesthetic drug to add to what we already had in our bag, and Propofol was discovered. It's a lipophilic compound. It was initially delivered in an oil suspension, and that caused some anaphylactic type reactions, and so that was taken off the market. And Diprovan, the current infusion that we have, is fat emulsion with soybean oil, and so that's the one that we use. It's a sedative and a hypnotic. We use it for induction of anesthesia, maintenance of anesthesia, sedation for procedures, and for sedation in the ICU. So a little bit about the pharmacology. The mechanism of action is on the GABA receptors. Remember, GABA is inhibitory on the brain. And so whenever you stimulate those receptors, then you get a sedative type effect. There's also antagonism at the NMDA receptors. Remember, glutamate is the neurotransmitter, and that's an excitatory transmitter. So when you antagonize that receptor, you get the same sedative type effect. So it works in two places. It's metabolized the majority in the liver, and we'll talk a little bit later about why we see some of the problems with liver dysfunction. It's because of that, because of the metabolism is mostly in the liver. But studies show that it's also metabolized in the kidneys and other body tissues too. And so most of the side effects we see in kids, at least when we use it in procedural sedation, the most common thing is probably burning. So it burns when it enters the vein. So sometimes we give lidocaine injection before we infuse Propofol so it doesn't burn so badly. It's a sedative, so you're going to get all of the things that you get with other sedatives, like respiratory depression. People can get apneic. You can get bradycardia, hypotension. It's a fat infusion, like we talked about, so you can get hypertriglyceridemia if you use it for a long time. There can be lactic acidosis. One of the weird things, if you have a patient on the floor and suddenly maybe they came out of the PICU and now their urine is green, and the nurse is calling you saying, oh my God, why is there green urine in this kid's Foley? And you go back and look and you see that they were sedated with Propofol. So it discolors the urine. And that's because it's secreted, like 88% unchanged, or 88% metabolites in the urine, so you get some discoloration. And then the more rare complications are fever. You can get pulmonary edema and propofol infusion syndrome, and we're going to talk about that. That's the urine. Green, pea green. Okay. So I didn't know this when I started to research, that we have doses that are recommended for kids. We have them in our Lexicomp Pediatric handbook for induction of anesthesia, for sedation, for maintenance of sedation in the ICU. So there are doses that are listed. And so you think, well, surely if these dosages are listed in all of our handbooks that we use, it's approved for use in kids. So when I went to look at the FDA recommendations, the FDA actually says that it's really not approved for use for ongoing sedation in kids. So we should really be judicious with our use of it when we use it in the ICU. It's recommended for induction of anesthesia and procedural sedation, but not for ongoing sedation. And that's because of issues with fatal arrhythmia in kids and propofol infusion syndrome. And then Canada has a similar warning that was based on the FDA recommendations that it not be used for sedation in the ICU.
Do you get permission?
Hmm?
You get permission from the parents?
We talk about it.
We don't get a written consent?
No. So, and both of those recommendations, at least from the FDA, came from studies when propofol was first being used in the 90s. Studies that had two arms. One arm with normal sedation medications like fentanyl and Versed, and then an arm that had propofol sedation. And so there were more deaths associated with propofol use and more propofol infusion syndrome related deaths. And so we'll talk about what that is in a little bit. And so that was where the FDA recommendation came from. Some of those things are not seen with short-term sedation, not seen with induction of anesthesia, and so I think that's why there's still an indication. And so the FDA recommends that we choose our patients wisely, that we adhere to a dose and duration limit, so we can kind of avoid some of the problems.
Does the Canadian board back go as far as to say that they recommend short-term sedation even, or I don't think so?
No, and only because it's not fully studied. We use lots of medications off-label, but just so you guys know, this medication is really common. We use it a lot. The whole hospital uses it for a lot of different things, but just so you know, you got to dig a little bit deeper and know what drugs you're using and know when it's recommended and when it's not. Okay. So this is a study from 2009. It was a German poll of ICUs, like 215 ICUs were polled about their usage patterns of propofol. And so what you see is that even with recommendations, even with limitations in use in kids, lots of places are still using it. And so almost 80% of ICUs did use propofol in kids. About half set age limits, protocols for use, and only about 7% used it longer than 48 hours, which is the recommended limit to not use it past for like ongoing sedation, like ventilator sedation and things like that. And then this is just a summary of all of the units that responded. So you see that majority of units used it at a dose limit about 4 per kilo per hour, and then for a duration of usually less than 48 hours. This is another study, kind of the same thing, a poll of the usage. And so about half of units in the United Kingdom that responded were using it for sedation in the ICU, and in North America, about 60%. We use it here less often, but we do use it also. Okay, so this is what I really want to talk about. Propofol infusion syndrome. In 1998, there was a study that came out by Bray and looked at a summary of 18 case reports of deaths in kids associated with propofol infusion. And so what they did was look at the duration that patients were on the infusion, the dose that they were on, what conditions they had, why they were being sedated. Because there were reports of this pattern emerging of kids developing bradycardia that was refractory to treatment, lactic acidosis that wasn't explained by any of their other underlying illness. They would have elevated triglycerides that would just shoot up, large livers, metabolic acidosis that wasn't explained by other reasons, and then some of them had rhabdo. So people started to say, is this connected to the use of propofol? What's the issue? Maybe we, thought we had a wonder drug on our hands, and now we need to go back and look at what's really going on. And so what they did was develop this criteria for diagnosis, and this is the criteria that we still use. So if you have a patient who's sedated with propofol and they have sudden onset bradycardia, that's one of the criteria that's required for diagnosis, and then at least one of the other criteria. And so we did have a patient in the ICU who was seemingly doing fine, suddenly developed bradycardia, and these kids, it kind of happens sometimes anyway in other conditions. Kids do fine to a point and then they don't anymore. But for this kid's case, and for most of the cases of propofol infusion syndrome that are associated with death, you slam them full of epi, put them on a drip, and nothing happens. You just can't get them out of that bradycardia, and then it kind of progresses into asystole and it becomes fatal. So out of those case reports, they wanted to look at a bigger time frame, a larger number of kids, and just see in a retrospective review if they could find out, were these symptoms associated with propofol? Were there any other confounding factors? And so they took the unit that had the most deaths, and it was only 3 deaths, but it was the most out of any unit that they had surveyed in that initial 18 case report series, and looked at the mean age, the duration of treatment, the mean dose, and what other findings were associated with the deaths in those kids. And they found that the mean age for the kids sedated was 3.5. 83% who had propofol infusion syndrome died. The mean dose of propofol was high, 8 per kilo per hour, and the mean duration was 68 hours. And so what happened was they didn't find any more additional deaths. And the kids that were sedated with other drugs, and during that time frame, no deaths occurred that had any of those symptoms that were similar to propofol infusion syndrome. And so this 48-hour time period and 4 milligram per kilogram per hour dose limit and time limit kind of came out of this original study. And so 4 per kilo per hour translates into about 60 mics per kilo per minute. And we usually use anywhere from 5 to 50 when we do our sedation. So just so you can correlate that for everybody who's been in the sedation unit. And so now we have a number because the kids that were sedated with propofol that had adverse events were sedated longer than 48 hours and at a higher dose than 4 per kilo per hour. So, it's maybe an arbitrary number that somebody just said, okay, this is the time period that we need to look at. This is the dose we don't need to go above because of the adverse events that we had seen. Okay, and so here, none of the kids who were on a dose less than 4 per kilo per hour or less than 48 hours developed propofol infusion syndrome. So that's where that limit comes from. So now we start to say, okay, maybe there is something here. Maybe propofol is associated with this constellation of symptoms. We need to look a little bit deeper and figure out exactly what's going on. Okay. Don't everybody get lost on me and zone out and fall asleep. We're not going to go that deep into physiology. But the main thing I want to talk about is impaired energy production and impaired cardiac function. So this is where we start to see most of our problems develop when we have propofol infusion. So in this article, it was a really good summary of all of the research that's been done, looking at the biochemical issues, looking at the energy production issues associated with propofol use. And so you get impaired fatty acid oxidation in the mitochondria, you get impaired function of the electron transport chain, and you get impaired use of your oxygen. And so all of these things kind of go into why you develop metabolic acidosis, why you get lactic acidosis, and why you can get some rhabdo type picture. Because if you can't use your energy correctly, if you can't burn your fats correctly, you know, your muscles start to lyse and you start to develop a buildup of acid. Remember that? Does that scare everybody? Ugh. So the problem with the mitochondria is that, okay, when you have a state of starvation or you have a state of critical illness, you start to burn your fats. And so you need beta oxidation, you need your mitochondria for that. And so in the face of propofol, you have a problem getting your long chain fatty acids into the mitochondria, and you have a problem with beta oxidation of your medium and short chain fatty acids. So remember, electron transport chain, it doesn't work. It's impaired function during the propofol infusion. So that's partly why you get so much buildup of lactic acid and why you get other organ tissues start to fail. This study looked at the function of the mitochondria in rat hearts and how the electron transport chain gets impaired. And so what they did was they combined propofol with the myocardial tissue. And here on the Y, this is the time to cytochrome C oxidation. Remember, the electron transport chain is an oxidation reduction reaction, so you need that cycling to be able to produce energy. And so what you see, this is the concentration of propofol down here. So as the concentration increases, the amount of your oxidized cytochrome C increases. And so if all of it's oxidized, it's not cycling through that reaction. So you're not producing as much energy as you normally would. And this is the same thing. This is the minimum cytochrome C oxidation at the end of an ischemic event and the concentration of propofol. And so you see that more of it stays oxidized, so you're not cycling through that reaction. You're not creating energy. Everybody with me? Too much science? No? Okay. This is interesting too. This is from perfusion of a rat heart with a buffer that contains oxygen and with a buffer plus propofol solution. So what they did was they hooked up the heart and they induced an ischemic event right here. That's the downward arrow. And they watched the myoglobin desaturate all of its oxygen, which is what you would normally want to happen, right? If you have ischemia, you want your tissues to dump oxygen. And this is the same thing here. So you see that your myoglobin desaturates. Once at the bottom, you start to perfuse it again, and then your oxygen saturation increases. When you start to infuse propofol, your myoglobin starts to hang on to oxygen more, so you're shifting that oxygen curve back to the left. And then when you induce an ischemic event here, like you just cut off the flow of the buffer, or you cut off the flow of blood like you would in normal tissue, the myoglobin doesn't desaturate fully anymore. So it's hanging on to more oxygen, so you're not delivering as much oxygen to your tissue. So you're giving a drug that impairs your oxygen delivery. So that's part of the impaired muscle function, that's part of the impaired cardiac function. And it doesn't look like, here's the downward arrow here, and here's the downward arrow here. It doesn't look like this little blip is a long time, but it was a statistically significant amount of time. So you're increasing your oxygen saturation, and you're taking longer to dump oxygen, and you're not delivering as much oxygen to the tissue. So I just think it's important to understand why you get all the weird constellation of symptoms when you get propofol infusion syndrome. Okay, this is another look at the oxygen. So let's see. So this is the time to 50% myoglobin desaturation. So it's kind of what we saw on the last slide. This is the propofol concentration. So it takes longer to desaturate your myoglobin when you have propofol being infused. And the minimum saturation of your myoglobin at the end of an ischemic event is higher. So you're holding on to more oxygen when you have propofol in your body, and you're not desaturating quickly enough when you have an ischemic event. Make sense? We lost anybody? Anybody asleep? No? Okay.
Sarah, at the concentrations there from the 200 micromolar? How do those compare to the?
So they're a lot higher than what we would use. They're much, much higher than what we would use in one of our patients, yeah. Which is usually the case when we do animal models, but that is important. Okay, so we have impaired energy production, energy consumption, oxygen consumption on one hand. We also have impaired cardiac function. So when you get that bradycardia that you can't get your patient out of, you have to know that there's a biochemical reason for that. There's decreased myocardial contractility, and there's antagonism at the beta receptors and at the calcium channel receptors. And that's bad for your patient who has bradycardia already, because what do you do if you have these receptors inhibited? What do you give to overcome it? It's really hard, and that's part of the reason why they're so refractory to treatment. So this is another perfusion study where we're looking at the pressure that's generated in the heart. So this downward arrow is an ischemic event, and you see that the pressure decreases like you would expect because you're inducing ischemia, so the heart can't deliver as much pressure. And it's the same thing here. And when you start to infuse propofol, your overall systolic pressure decreases in general, and then you induce another ischemic event, and then you get an even further decrease in your systolic pressure. So it's a double hit. You know, you have a patient who's really sick, they're septic, they might already be on pressors, they have a lot of stress, so they may already have decreased myocardial function, and then you add propofol on top of it and you further decrease their myocardial function. And then most of the studies that looked at hypotension with propofol use found that the blood pressure doesn't really change that much. And so this graph kind of illustrates that. So your systolic pressure changes and your diastolic pressure rises, and so you get this really no change in your mean pressure, but this starts to approximate what the shock blood pressure does. So as your body decompensates, your pulse pressure gets a little bit narrower as your body's like clamping everything down to try to compensate for the fact that you're having decreased systolic pressure. So even though your blood pressure is the same, it may not really be a good thing because you're altering that physiologic normal. And so this looks at the actual myocardial contractility in the face of pressors. So the developed tension in myocardium, the pressures that you're generating when you're contracting, these open circles are with isoproterenol, so with a pressor. You're generating higher pressure at a higher concentration. That makes sense, right? When you add propofol to it, you're not able to generate as much pressure. And then over here, this is the rate on the Y and the concentration of isoproterenol on the X. And so here, your rate, when you're just infusing your pressure, your rate will go up. And then with propofol, your rate doesn't go up as high. So you're not contracting as hard, and you're not creating as fast of a rate. It was a rat. It was a rat atrium. Yeah. No idea. It was an isolated rat atria. They actually dissected out the atria. They gave him a lot of isoproterenol. Am I going too fast? Like I'm zooming through it. Okay. And so this one looks at the actual beta receptor. So we need our beta receptors to respond to our catecholamines. And so this study looked at, it was rat hearts again, and looked at what propofol does to the beta receptor. And so this compound is a known beta receptor antagonist. And so they mixed this heart tissue with this known beta antagonist and looked at the binding on the Y of that compound to the heart. And so this open circle is your control. So you see this binding that approaches a maximum right here. When you add propofol and you look at the binding of this compound right here, the binding is less. So there's a picture that looks like competitive inhibition of the binding of that compound to the heart. And so the conclusion they came to was that in the face of propofol, there is some interaction of propofol with the beta receptor itself. And so that could be a basis for why, when we start to give epinephrine to these patients who develop bradycardia, they don't respond. And the same authors looked at calcium channels as well, a known calcium channel blocker. For some reason, they switched up their control and their propofol group with the open and closed circle. So this is the control up here. And so you see a kind of similar thing. There's a competitive inhibition at the calcium channels. So there's some interaction of the propofol with those receptors. So you have, low pressure in your heart, not able to contract as much, and you have impairment of the interactions of your normal catecholamines at the receptors in the heart. Okay. What does all that mean? Does that mean that we shouldn't use it? Does that mean that everybody that we sedate with propofol is going to get propofol infusion syndrome? No. But there's two things at work. There is the problem with the priming factor, so whatever their illness is, and then there's the triggering factor, which is the propofol use. And what we really want to know is when is it safe? Are there any patients that we can identify that shouldn't get the drug? Are there any patients that we can say, this and this and this is what we need to watch for and monitor for and prevent it from happening? I won't go over that. This is the initial chart that I found, and I simplified it. So you got your critical illness. Your body produces your inflammatory response, which is your own steroids, your own catecholamines, your own cytokines. And they all interact with your energy production, with your musculature, with your heart, and kind of prime your body for being able to respond to all of that stress. But being in that stress state, you already have some myopathy because you're not metabolizing your energy like you normally would. You're already having some peripheral organ issues in really sick patients. And then you add on top of it, some of these patients you're giving catecholamines to, you're giving pressors, some of them you're giving extra steroids to, and you're adding propofol. So it becomes this perfect storm of issues in the body that creates this environment that allows propofol infusion syndrome to happen. We know that people who have traumatic brain injuries, status epilepticus, meningitis, are at a higher risk of developing propofol infusion syndrome. But this is also a group of patients that we use propofol in. If you're in the neuro ICU, they use it a lot because sometimes you need to wake your patients up to be able to examine them. And the good thing about propofol is that it has a rapid onset and a rapid off too. So the half-life is short, the time to induction is short, and so if you need to wake somebody up, it's a really good drug to wake somebody, to be able to turn it off and wake them up and examine them. But that increase in steroids, sometimes you're using exogenous steroids, that increases your risk to have propofol infusion syndrome. And these are just two, this is a case, the top one is a case report of a person who developed symptoms of propofol infusion syndrome. The infusion was stopped and then they recovered. But it was a traumatic brain injury patient who was on steroids and pressors. And then the bottom study actually looked at about 70 patients with traumatic brain injury who had propofol infusion syndrome, and they were at 2 times the risk for every 1 milligram per kilo above 5 per kilo per hour. So the risk increased significantly as you increase the dose. They were adults, not kids though. So, okay. So now we know we have a risk. And now we want to know who we can use it on, and if we can monitor for the development of propofol infusion syndrome. And if we monitor for it, can we stop it from happening? So in this graph, this was a 17-year-old boy with a traumatic brain injury who was sedated with a really high dose of propofol, 8. And he was sedated with that dose because he was becoming awake and trying to extubate himself. And so they were monitoring every 12 hours his lactic acid, probably because he was a trauma patient, because he had other injuries, and also because he was on propofol. This is the dose of propofol. It was decreased, kind of titrated, which is what we normally do. And at this point, he developed a need for a pressor. And then here, his lactic acid started to skyrocket. And then it went higher. We stopped the propofol here, still kept climbing, and he ultimately died. And so we kind of saw this in the patient that I had. He was fine, trucking along, lactic acid was like 3, and then 12 hours later his lactic acid was 13, and then 2 hours later it was 26, and then it was higher and higher, and even after stopping the infusion, he still died. And so, this is showing us that even if we monitor for it, doesn't always mean that we're going to be able to reverse what happens. Yeah. Our patient was on propofol less than 48 hours. Yeah.
Sarah, one thing that's interesting is that the half-life for the sedation is very different than the half-life for these
for the long-term infusion.
catecholamine effects and antagonism, and that's really gives you two different pharmacologies to have to worry about.
Yeah. Yep. So the half-life if you just use it for procedural sedation, most of it's cleared in about 40 minutes, and then terminally cleared at about 4 to 7 hours. But if you have a consistent infusion, then it takes days, like 3 to 10 days to fully clear the drug, and it's lipophilic, so you're going to store it up in your fat. And so if you have an obese patient, then you can turn it off, but who knows how much they've distributed into their fat, and that can leach out. And so you have to think about that when you use it for sedation too, because if you're pumping them full of it, and sometimes kids take a lot of propofol, you can turn it off and they may not wake up when you expect them to wake up. It may take them longer because they've got a bigger volume of distribution. Okay, so we have this number, less than 48 hours of sedation. We have a number for the dose, less than 4 per kilo per hour. Do we need to create a protocol for how we sedate our patients? Is that helpful? Does it prevent deaths from propofol infusion syndrome? There are a couple of larger scale studies that support that having a protocol is a good thing. We're going to talk about them. And most of the cases where you're using a smaller dose, you may have to use something else too to keep them sedated. And I think in the beginning when we started to use propofol, we kind of thought, well, this drug is so great, we're going to be able to use it to keep them sedated and not have to use anything else. Because our other options are using a paralytic and a sedative, or using 2 sedatives together, and no one wants to create that much polypharmacy in their patient. But I think we know that maybe propofol by itself is not really the best thing. So this is about 200 patients, kids in Canada, and they have a protocol in their ICU that they don't use more than 4 per kilo per hour. They do give a bolus of 1 per kilo per hour only if they need extra sedation, and the nurses titrate it to the level of sedation, and they use it for a max of 24 hours. So most of these kids, they're using it not for ongoing sedation, but for weaning off the ventilator. And so if they're sedated on something else for a while, they transition them to propofol when they're getting ready to wake them up, because it can be titrated more quickly. So you see it's the same thing from the other slide. Really, most of them are on less than 4 to 5 per kilo per hour, less than 24 hours. And no kids in this 200 case review developed propofol infusion syndrome. And they were admitted for a variety of reasons, like post-cardiac surgery, respiratory illness, shock, sepsis. And this is a similar study with almost 150 sedated with propofol. They use a max of a little bit less, 3 per kilo per hour. And you can see majority adhere to that. Majority are less than 48 hours of sedation. And no documented episodes of propofol infusion syndrome. They did have 10 patients that died, but they died of various different illnesses. They don't say anything about whether they developed bradycardia and arrhythmia, which would have been helpful to know if maybe they did meet some of the criteria or not. But units are using a protocol for drugs, and it may be a way for us to limit the adverse events that we have if we would develop a protocol for use here. So just to summarize, we know that we use it, even though there are some FDA recommendations to watch out for the adverse events. There is good literature that documents that there are biochemical and physiological evidence of why we develop the adverse events that we do. You know, we know that sometimes even if we monitor closely, there's nothing we can do about it once it develops. And so we all have to keep in mind that this could be the problem. And you know, if anything, if you have a patient on a medication, they start to develop adverse events, you turn it off and just see what else you need to do. And you do your labs and you try to figure out what's going on. But I just wanted everybody to know about it because, you know, sometimes we don't think about it. We get really comfortable using a medication and then we forget that, you know, that lactic acid that's spiking could be related to the infusion of their medicine. Large-scale studies show that if we develop a protocol, it can be helpful. If we adhere to a max dose and if we think about our patient, you know, our patient's whole picture. I think it's really hard because your patients are so sick. They have so many other things that can explain why they're developing these type of symptoms, but it's just important to know about and just to know that it can happen. I think that's it. Dr. Pramanik.
Excellent presentation. I've not seen very many people who can correlate physiology, which is so important in any ICU or pathophysiology with the drug. Several questions and a comment I'll put in the end. Questions is on patients here. You know, most of these patients are pretty sick. Case you described nicely. Obviously, you said it was obese. So I was wondering whether the drug is being absorbed in the fat and slowly released. Because when we talk of pharmacodynamics, as you well know, there could be individual patients, and also there are, you know, whether you were taking one compartment model, two compartment model, three compartment. So what I'm saying is this is minimum 3 compartment model here. So you have to be very careful when something is happening. Now that's one comment. So this patient has ARDS or other problems, because one of the things that's coming in my mind as you presented, in PICU we are dealing with extremely sick patients who may have multi-organ failure, and therefore the biochemical processes in the myocardium or the liver, as it is visualized here, could be altered or be there for altering this. Keep that point in the back of your mind. So has anybody looked at clinical diagnoses of these patients, lactic acid levels, liver function tests, myocardial enzymes, and correlated with the outcome, whether it's clinical outcome or lactic acid levels?
So there are some studies that look at retrospective reviews of the literature, and the problem comes with the fact that sometimes they're monitoring lactic acid levels, sometimes they're monitoring LFTs, but it's not, you know, strict every 12 hours. It's not things that we can compare from one patient to another. As far as the volume of distribution, I don't think there's been anything that I saw in humans that they studied anything with that. But that's the problem. And there was an article that I read about, are we ready to go to a big prospective study, a randomized controlled trial in kids? I don't know that we ever will be there. But yeah, that's a good point.
And I think you should do it, because you beautifully presented just now the problems with a retrospective study, that you don't have all the clinical parameters, but you see in a myocardium apparatus completely different. And the human myocardium are different ages and different disease states, the saw and all that. But one has to take that into consideration. So that's an important point. And the other comment I want to make is, I was hoping to see a slide with Michael Jackson and the doctor together.
I'm sorry, no Michael. I won't say any Michael either.
Sarah, one question. Do we know, I know that propofol is used a lot for outpatient procedures in adults, colonoscopies and like. What's the rate of complications in that population with those sort of very short-term uses?
Almost none.
Yeah. Yeah.
Almost
So
none.
that's a reassuring thing.
Yeah,
that's reassuring.
And none in kids either.
The anesthesiologist for several years saying it's malpractice if you're not an anesthesiologist and give the drug. And there was big fights at the AGA, and finally they've come to it and they agreed that if the gastroenterologists are trained, it's very safe for them to do it. A lot of this data we owe to Paul Jordan here, when they said they had, with a couple studies, they had a couple 100,000 patients failed or were in the trial, and they did well, that it's done. I think that one of the messages here is that the FBI the FDA can approve drugs, but once they're approved, you can still use them without being off-label. And I'd say 20 to 30% of the drugs I use are off-label in pediatrics. So you just have to learn to live with it.
And that doesn't mean that they're not safe, but it's important for us to know that, to know what can happen.
I would point out that Lasix had gone through 3 editions of the premier cardiology book for children before it finally got approved for use in children by the FDA.
Yeah, John, also what's happening here is you're in, right, so you've got drug-to-drug interactions, so currently not. A lot of these kids may be on other sedation which acts in the same membrane or receptor.
Of course, this is why the FDA is now given or demanding that all new drugs that may have a use in children, they may approve them, but they have to agree to be doing studies on their use in children, if there's any conceivable use in children.
One quick comment, the other contraindication to using this is kids with mitochondrial disease.
Yeah, there's some studies. Yeah, there's some speculation that there could be genetic basis for the problems that we see, because not all kids who are sedated with high dose develop propofol infusion syndrome, and some kids sedated with lower dose develop it. So I don't know that we're there at elucidating what mitochondrial mutations are responsible for this, but there's a thought that it could be a genetic mutation.
My question is, did the coroner say that he had propofol infusion syndrome, or that's what we're saying?
No, I mean,
there's a lot of things that he didn't have that fall under.
Yeah, that's true. So he did have elevated liver enzymes. He had some pulmonary edema. This kid had status epilepticus, and he was sedated for less than 48 hours. He had an ARDS type picture when he was on the ventilator. But the lactic acidosis, the resistant bradycardia are the only 2 criteria that he really fit. His heart was enlarged, his liver was enlarged on autopsy, but the final report didn't say that it was propofol infusion syndrome. And I think it's really hard to say whether it is or isn't when you have a kid that has so many other medical issues at work. But yeah.
Yeah, because he didn't have rhabdo, he didn't have hyperkalemia. I mean, he didn't fit a lot of the criteria. So when you're looking at how many case reports of propofol infusion syndrome there are, there's not a set criteria.
Yeah.
So it's really hard to say how many cases there actually are. And so some people say there's only been, a few case reports. Some say there's more like 1,300. Yeah. But out of those 1,300, only 30% death.
Yeah.
And so it just depends on what you're using as your criteria to diagnose it. Yeah. And so that's real important to kind of look at. And then in the mouse studies, they're showing just in a short period of time that their heart was becoming refractory to different things. How high, do you know the dose, how high the dose was for those?
No, it's significantly, like triple, quadruple, significantly higher.
But that's what we use in procedural sedation.
Yeah. So
we're using much higher than 50 mics per kilo per minute. Yeah. But it's a much shorter period of time.
And who knows, that's a limitation too, because who knows if that initial effect on the heart lasts for as long as the whole 48 hours that you're sedating them, or is it just the initial infusion that produces that drop in heart rate and a little bit of hypotension. So there's more work to be done. But that's a good point, Colin, because when you go through your case reports, do you look at all 5 criteria? Do you look at just 2? Because how many patients in the ICU develop lactic acidosis and bradycardia? I mean, virtually everyone. So,
and in a code situation, a lot of them become refractory.
Yeah, that's true.
I mean, just pushing epi after epi after epi, and that's somebody that hasn't even had propofol. So
it's the natural course.
Right, and so I don't know, just.
I'd like to offer just a final comment when we talk about syndrome. This goes back to Spiro about 30 years ago. He was an adult gastroenterologist at Yale, of all places. And he said, what we do is we put names on things and we're very comfortable. And all they are is that what we do is we group of patients and we say what usually works on them becomes a useful construct. But they may have multiple different diseases that are closely related. And I think we're seeing this in Crohn's disease now. Why is it that no matter what drug we use, they only work in about 85% of the cases? We're realizing that there are probably several subsets of disease, and we're just not smart enough to name it on each.
Yeah,
and so when you talk about syndromes, it tends to make us very comfortable in our ignorance, and I think we have to guard against that.
That's a good point. I want to let Dr. Wilson weigh in on a couple of these pharmacologic issues and perhaps on drug, on off-label use in children.
Well, the latter aspect, pathophysiology of this drug is well described by you. It's a very good presentation. Pathophysiology reminds me of two other drugs that came to the attention of pediatricians for their toxicity. One very early on is chloramphenicol, a mitochondrial poison. The other, very familiar to us, is aspirin, uncouples oxidative phosphorylation. So now we have another drug, kind of same story, but a little bit differently, especially in terms of its pharmacokinetics. And with regard to that, I'd like to pursue Dr. Monik's comment and Dr. Vancheri's comment. There is a discordance between the clinical effect and the half-life, but it depends on where you are in the model that's operating on this drug. Initially, you get a rapid distribution into organs of high blood perfusion. What are these? The heart and the brain and the liver. Now, if you stop your infusion there, basically the process reverses itself. The drug redistributes into plasma, and the half-life has a closer correspondence to the clinical effect. But if you continue to dose, and that's where the dilemma is here, then you start looking at other parts of the model. The model that operates most of the time for this drug seems to be with prolonged infusion, a 3-compartment linear model, or some people call it a sequential model. So you have 3 little boxes connected. The first compartment, of course, is the plasma, and that drug from the plasma distributes into the second little box in the model, brain, liver, and heart. That gives you the short half-life, very short. The second half-life, which is measured often in hours, has to do with the elimination of the drug by the liver, mainly, and metabolites are excreted in the urine. The elimination by the liver is mainly through glucuronidation and sulfation. So that is the second half-life in the PK profile if you measure it long enough. Now, the real problem is, as I see it with this drug, is the third box in a 3-compartment model. That's the deep compartment. Any drug that you see a very high volume of distribution for speaks to a deep compartment. That's where you get the long half-lives. Now, in regard to stopping the infusion and seeing an improvement in the clinical state of the heart and the liver and the metabolic acidosis and other things that you well described, one must bear in mind that deep compartment behavior drugs operate with micro rate constants on an amount of the drug in the compartment. Now, the micro rate constant in this example, K2, K3, puts the drug into the deep compartment. For example, PhET was mentioned. Now, the dimensions of the other rate constant to get the drug out of that deep compartment are not necessarily the same. In other words, K32 are not the same as K23. And in that case, there's a slow egress of drug from the deep compartment. But it's not only dependent on the rate constant, it depends on how much drug, i.e. the amount, you've got in the deep compartment. And I think that's where we get into trouble with this drug. So you have an uncoupling of half-life clinical effect, if you will, but probably impacts more on the toxicity of the drug. So you go backwards into the first compartment and the second compartment, and the drug is metabolized and excreted. But you still got this large amount sitting out here that the micro rate constant is acting on. And I think that's, for this drug, where we get into a problem, and the fact that most of the patients with PRIS actually are those that have a prolonged infusion rate. So this is one drug that at least we think we can explain the toxicity in terms of the pharmacokinetics of the drug, as well as its intrinsic pharmacology.
Thank you, John.
Can I make one more comment and a question? What is the youngest age that was used in the German study? You said NICU and PICU patients, because as you're developing the protocol, also I would like to consider, at least, that please take informed consent on a drug that is not approved by FDA and is a dangerous drug. Because you'll land up like Michael Jackson stays one of these days. You know, somebody can turn around and say,
I don't want to drug.
Right. That's what I'm saying, that be careful.
Most of the PICUs did not use it. It was just a probe for NICU and PICU to capture all the kids. But the great majority was PICU patients. And the age, I think the mean age was about 3 or 4 years old. So it was less in NICUs there. I don't remember what the minimum age was in that study though.
And then just the last comment, I think that many of you know that Dr. Wilson was the first person to identify by going through the PDR how many drugs we use in children are really off-label. And I think when you first did that, it was 85%? 80%. And then with the Pharmaceutical Acts for Children, which we gave an opportunity for drug companies to make a little bit of additional, I guess, a prolongation of the patent of the drug by studying drugs in children. You got that down to 50, well, 6 months prolongation, but now in the most recent review it was down to 50-some-odd% of drugs were still off-label in children. So unfortunately, as caregivers for children, we have to use many drugs based on what we get from adults, and then some post-licensing studies that are done by specific investigators like Dr. Wilson over time that led to better understanding to use them even though they're off-label. So it's a serious problem that still exists. So Sarah, thank you for an excellent presentation.